Hello, namaste and good evening, or good afternoon from the UK, really. Um, this is the first in the series of webinars from MeHeLP India, Mental Health Literacy Project in India, to actually explore and promote mental health literacy in Kerala. I am Raghu Raghavan. I'm a professor of mental health at DeMontfort University in Leicester in the UK. And I lead this UK Research Council funded project on mental health literacy in urban and rural communities in Kerala using applied theatre methodology. Let me just, before I go and introduce our chief guest, let me say a few words about the project itself. Mental Health Literacy Project works in 4 districts in Kerala, in Calicut, in Malappuram, Palakkad, and Ernakulam. The idea is that we work with people with mental illness and their immediate families and people in their neighborhood to actually explore their social, cultural perspectives on mental illness and how they actually seek help, with a view to try and promote how to seek help and what are the ways of actually improving mental health literacy using theater, films, and other creative media approaches. We have been working in Kerala since September 2018. And we have engaged with a number of communities, both urban communities, rural communities, and tribal communities in early part of 2020. We had to pause because of the pandemic, but we are trying to restart the schedule again. And we have engaged with the communities in Kerala using another mode of film. We recently hosted the MeHeLP Short Film Festival to engage with wider communities about awareness of mental health issues. So we are actually at a point whereby we want to talk to the wider communities, wider people in Kerala as to how we promote mental health literacy. So what is mental health literacy? Mental health literacy actually consists of 6 different components. Mental health literacy is not just mental health awareness. Mental health literacy looks at, firstly, our ability to actually recognize mental health conditions or any symptoms of mental distress that one may actually experience. And secondly, it looks at our awareness, our knowledge, our kind of understanding of knowledge or causes of mental illness or mental distress. And thirdly, it kind of looks at self-help models. What are the kind of things that we can do ourselves in relation to manage mental distress and also mental illness, possibly? And fourthly, what kind of knowledge do we have in terms of professional help available to treat and recover from mental illness and mental distress? And fifthly, it looks at attitudes that facilitate and promote better awareness of mental health in the wider community, including employers and everybody else. And sixthly, it looks at knowledge of how to seek mental health information. And we do know that low mental health literacy actually it's a factor in disabling people to actually seek help at the appropriate time, and it actually gets to some kind of a crisis point. So, and hence the need for better mental health literacy, as it is actually stated within the National Mental Health Survey of India in 2017. So I have great pleasure to inaugurate the second series in this webinar on mental health, promoting mental health literacy in Kerala. And we have a distinguished guest whom we will be discussing the issues around promoting mental health literacy from the public health perspective. And we are very grateful to have you, Dr. Shaji, with us to discuss this important topic on mental health literacy. Let me introduce Dr. Shaji. Dr. Shaji is trained in psychiatry from the Christian Medical College in Vellore. He joined the CMC Vellore and then the Government Medical College Thrissur. He was a professor and head of the Department of Psychiatry at Government Medical College Thrissur till 2020. He is currently the Dean for Research at the Kerala University of Health Sciences in Thrissur. He has published widely, well over 60 peer-reviewed papers in national and international journals, and he has also contributed to chapters to 8 books. He has also received a number of national awards, and he's also a member of our project advisory group for the MeHeLP research project. So we have great pleasure to welcome you, Dr. Shaji, to this first webinar on public mental health and factors that we should be taking into account in promoting mental health literacy in Kerala. So first of all, welcome you. And also, I'd also like to welcome all our viewers, both on Zoom and also on Facebook. Thank you for joining us, and good to have you. And we would actually have some discussions with you with questions at the end of the webinar. So, Dr. Shaji, can I come to you in relation to what is the understanding of mental health literacy in Kerala? I know Kerala is very advanced in terms of healthcare provision in par with many of the Western countries, but what is the understanding of mental health literacy in Kerala?
I think mental health literacy or health literacy in general had been improving over the last 10 years, much more so in the last 10 years than, say, last 30 years. I think this has improved along with improvement in health literacy in general, and mainly through efforts by mental health professionals who had used print media and extensively to educate people about various mental health conditions. But then uh, this was not an organized effort. This was led by people who were very passionate and skilled in writing and communicating to people through health magazines, especially handling columns on mental health in health magazines. For example, I think uh, they, more than 1 lakh of copies are being printed uh, by 2 major publishers, that is Madhubhumi as well as Malayalam Manorama. They publish a monthly health magazine, which has circulation, each group will have circulation of more than 1 lakh. So that's quite a bit of readership. That the publication of those 2, and then this was followed by many other publishers. These are the 2 leading uh, magazines. The advantage of having a magazine which comes once in a month is that you have something which is readable for a month and at home. Unlike the newspaper, which loses its relevance, say next day or 1 or 2 days later. Nobody reads the newspaper of yesterday's or day before yesterday's newspaper. So, in fact, when they started, some of us were consulted, and we said that mental health is an integral part of health literacy, and promotion of health literacy should be their declared goal, and they had committed themselves in doing that. And very interestingly, uh, in the month of October, when we have Mental Health Day, some of these journals or magazines had brought out special issues on entirely on mental health. There was a remarkable issue by Arogya Masika as well as later on by Manorama. That issue was exclusively on mental health. And there were issues in which they had addressed depression as a major theme in one of the issues. Sometime back, late dementia as one another issue. But as I said earlier, these are led by publishers because they understand that there is readership interest in this, and by people who have the time. And I think I must also acknowledge here that it would have been difficult for most mental health professionals to devote time to write up articles which are publishable and are quite good in communicating mental health related matters in Malayalam. That requires lots of time. I had personally done that a few times. So that kind of time was difficult maybe in the 90s and early 2000. But then now that we have more mental health professionals, we have more people who are adept in writing very well. And then the last 10 years, it's seen more people taking up other medias like audio, visual, and then, of course, social media to propagate or to disseminate quality information on mental health. So that's something which has really led to a surge of activity, I must say.
Okay. So, with all the health literacy in India, but there is a high incidence of mental illness and suicide rate in Kerala. Why is that? And what's the kind of social, cultural, and other kind of trigger factors that might be contributing to that?
When it comes to suicide, again, there could be various views on that. I personally do not believe that the reported rates from other states actually reflect true rates from there, because Kerala, for that matter, health reporting of deaths and births, and especially suicides, uh, uh, probably we are much better off than rest of India. Again, when it comes to morbidity, most of the studies on mental health morbidity had focused on severe mental illness and not so much on common mental disorders. And these studies are not strictly comparable. So I personally do not believe that we have a higher incidence or prevalence of mental illnesses or mental health problems. But then, like Punjab, Kerala and some other northeastern states have a higher prevalence of alcohol and substance abuse. That could indirectly contribute to higher disease burden. But then I'm not too sure about higher disease burden, though there are indications from global burden of disease study in that direction. That's something which we need to look at in detail.
Okay. And what about the social cultural understanding? Because the stigma still holds, because that is actually preventing the kind of the filtering of the health literacy and mental health literacy, because people are still may not be seeking help because of the stigma around mental illness. And you being a practitioner within the Kerala context, what are your thoughts about that, the stigma, and how we might overcome some of that in terms of promoting mental health literacy?
I think stigma is very much there, and I think I'm not sure. I think every society, according to my perception, every society will go through a stage of increase in understanding about mental illness, which immediately will not get translated into reduction in stigma. Only when good understanding and good comprehension uh, is available to the general public, then only people will start seeing mental health as any other health problem. At the moment, people are impressed by very obviously abnormal mental health conditions, and they generalize this to all mental health problems. For example, something like schizophrenia, something like schizophrenia, something like bipolar disorder, something like dementia, is usually equated with all, or they are considered as prototypes of mental health problems, which is not true. This is one area where we have really failed. I think this is not a problem specific to Kerala. This is a global problem regarding mental health literacy. We need to actually focus our movement to improve understanding about the commonest mental health problem, that is depression.
Yes.
Then we must address anxiety disorders, because anxiety is a much more experienced emotion uh, across human beings. So people are able to identify with the subjective experience of anxiety, and then it's very easy to sell this idea that when you have very severe forms of persistent anxiety, that's called as disorder. Uh, this holds true for depression also. I think uh, one of the unfortunate things which has happened probably globally and definitely in India is to give lots of emphasis for conditions like schizophrenia, bipolar disorder, which are recurrent and rather persistent forms of severe mental illness. So people tend to consider every mental health problem as something which has got shades of schizophrenia or psychosis. And thus, because of the disability and burden associated with such illnesses, people tend to think that these are chronic, difficult to treat mental health problems. So the ultimate outcome of that is people with depression would think that I don't have psychosis or abnormal behavior like the concept of mental illness among lay public. So thus I don't require treatment. I have a different problem. And they try to find out causes and develop explanatory models which actually will be psychosocial rather than biopsychosocial. So then they might not want to take drugs, for example, antidepressants. So some of us had been trying to focus and correct this problem. That is to to educate people about depression, which could be biological in a significant proportion of cases, and then would be reversed by treatment which would normalize the abnormal biology which underlies the uh, condition, namely biological depression. If we could get this idea across, it's not easy. I think it's very difficult. But then if we succeed in that, then it will be easy to explain schizophrenia, and it will also be easy to explain some of low grade stress related issues, relationship issues, etc. So I think this is one stumbling block for uh, getting more people to accept that mental health problems are indeed common. And another missing point is that depression is eminently treatable. Depression remission is the rule, and nobody continues to be depressed till for many years. So these ideas had not really transpired uh, or got disseminated to the general understanding of the society. I think that's a major problem.
Okay. So, I mean, I think thank you for that. I think that's a point well made in terms of both the kind of severe mental illness and the major prevalent illness of anxiety and depression, which people may not recognize and may not actually seek the treatment. So, how Kerala has been through a number of things in terms of recently we had the floods and we had the pandemic, and we still have the pandemic, and what are the kind of lessons that can be learned in relation to mental health literacy from the initiatives that Kerala has actually taken?
I think this was a series of problems, two natural disasters and two outbreaks of infections, and the ongoing one. And I was also part of all this governmental response, if I could qualify the response in that way, wherein we saw tremendous opportunities in terms of, for example, when the floods happened, I was summoned by the district collector to advise the administration on handling stress and the aftermath of the devastation caused by floods and how it has affected lives of people. And that was not that we volunteered, we were summoned and put in charge of looking after that. So I think mental health was recognized as an important ingredient of any package of care when something of this proportion happens. Uh, that's an advantage. In this pandemic also, same thing has happened. People had fear, anxiety, stress, suicidal behavior, alcohol withdrawal, delirium. All those cases could not be managed by people who were trained in general healthcare only, which in fact has exposed the poor quality of training for undergraduate medical graduates in Kerala, because many of them were unable to diagnose delirium tremens, for example. They were unable to pick up delirium early, and they were unable to offer care for people with depression and anxiety. Uh, the only negative regarding this is that, see, this is being seen as a need in response to a physical illness of big magnitude. Here, they are not talking, or they are not really bothered about what is almost always, which was almost always there. For example, 8% of, we have shown that 8% of people in Kerala has common mental disorder. That is the prevalence rate from 5 districts which we estimated. And there will be, put together about 12%. That would include psychosis, alcohol-related problems, dementia, cognitive impairment related issues. So about 12%. We are talking about 1 in 8 of people above the age of 18 needing some sort of help. This is pre-pandemic burden. Nobody is talking about addressing that pre-existing issue. My only concern is that when this emergency becomes redundant, then we might end up fighting for, more services and more investment and more care of those. This is true about non-communicable disorders in general and mental health problems in particular. That's my concern.
Okay. So, I mean, I think focusing on the kind of public mental health, which is what we said that we will talk about. What about kind of what are the innovative ways that we can promote mental health literacy in the concept of public mental health?
One good thing which is, see, what's happening in Kerala is, again, we are the first Indian state to accept that district mental health program is an important program, and the government had no hesitancy in rolling out this program in all 14 districts of Kerala. That, I think, is a significant milestone in scaling up specialized services across the state. So I think, but then issue is there are hidden problems which are not getting identified. Having been part of this mental health program at Palakkad district in the first 2 years of its beginning, my concern is that this program is likely to address severe mental health problems, which are acute psychosis, chronic psychosis, recurrent mental health problems, and maybe little bit alcohol related problems. But beyond that, the people who seek help there do not seem to come for management of common mental disorder, which is widely prevalent as shown by both the National Mental Health Survey and our own survey. It's about 8-9% that of adult population. So that has to be addressed, and we will have to find ways of doing this. One of the thought which some of our colleagues and myself are trying to convey to the government is that we need to integrate this into ongoing programs. One good example is maternal and child health program. Recently, there is an ongoing confidential review of maternal deaths, which is happening in Kerala for the last few years. They had sought our help because last 2 or 3 years had seen a large increase in the number of suicides during, antenatal and postpartum period, which is a matter of concern. And during the interaction with healthcare professionals engaged in providing maternal care, we found that none of them or most of them uh, do not have a good understanding about depressive disorders. At best, they can suspect some symptoms of anxiety and depression, but none of them are skilled or knowledgeable to diagnose depressive disorder among mothers, young mothers. I think that has to change. Every obstetrician should be in a position to suspect and to with with reasonable certainty they should be able to make a clinical diagnosis of depression, which is very obvious in most cases. So that is one area which the government and the government has accepted this in principle, but then of course last 2 3 years had put the government to allocate and deploy resources for acute care, and the NCDs in general had taken a backseat. But then we could convince the government to integrate mental health care into maternal and child health program. That will be done sooner than later. Secondly, there is a very interesting program which is ongoing. It's called Vayomitram. It's decentralized healthcare for older people, people above the age of 65. That we started with cities, and that's being rolled out now into rural development block, that those rural areas also. There, depression among older people is frequently encountered. So there is a window of opportunity where we could identify depression and cognitive disorders among older people. So that's something which is good, which is happening. Thirdly, I think it's all about adding uh, community outreach services to the ongoing district mental health program and investing more time and energy into mental health literacy programs across their area of jurisdiction or catchment area. So if that can be done, that would be very good. This is my take on this.
Okay. Okay. I think, yeah, we mentioned training and awareness as a major issue there. But what about in terms of the rural and tribal communities? Because my experience is that the little experience in Kerala, obviously, when we wanted to talk about mental health issues in the urban community, in the cities, not many people actually attended those sessions, whereas we had large number of people actually attend in the rural and tribal settings. So how do we try and to kind of balance the kind of services and the kind of initiatives both within the urban and rural communities in Kerala? Because that might actually have implications in the rest of India as well.
You're absolutely right. I think there is poor participation in community or poor cooperation to any community outreach service when it comes to urban areas. For example, an ASHA worker or an Anganwadi worker or a public health nurse, they are not very happy, or people are not very happy to interact and take help uh, from people who offer healthcare near homes or at home. This is something, I think, this is about privacy and also about stigma, also about information. Whereas, and this is, I think, again, this is that community participation in healthcare itself is less in urban areas. People do not volunteer or people do not join volunteer work in urban areas. There is this, uh, this is evident in palliative care also. Rural areas have more acceptance for home-based palliative care services than urban areas. Uh, I think there there may be a negative impact of higher social and educational status, and that is somehow becoming a barrier to take help and give help. So this has to be addressed. Actually, this needs to be looked into in great detail.
Yeah, yeah. Okay. So, but I think there is somebody actually mentioned within the audience. Somebody has actually mentioned that the awareness of the depression program, and they also say experience similar issues in other states as well, in Mumbai especially, in this particular question. So how do we try to overcome some of those things?
I think we need to identify homogeneous groups who share values and uh, who are happy to share social spaces. And then this has to be left to people who are motivated, who has the time to volunteer. And in urban areas, one thing which is being looked at uh, is to take residents associations into confidence. This we have done for dementia care and elder care in general. So therein, we had made few visits in Thrissur. We had small gatherings of residents association meetings, and then we talk about, because geriatric healthcare problem is much more visible, and there are lots of takers for such help in urban areas also. So residents association will have one or two people who were either caregivers themselves or currently are caregivers, who are willing to offer help or help to help each other, kind of thing. Then we had meetings. Again, that's another thing which may be of interest to this program. We have had gatherings of uh, uh, business. This is called Vyabari Vyavsayi Association. They have periodic meetings wherein they are happy to have uh, information on health related issues, and mental health had uh, been a fairly sought after topic. So again, there they will have lot of active members who are offering such information and guidance to people who are in need of that. So that could actually facilitate help seeking and identification of cases. So we may have to work with social groups, religious, business, residents association. Um, uh, I think that is something which people, the member should be a stakeholder in that group. So that will work better.
Yeah, yeah. I think there was a comment from the audience stating that there are some. I think it's from the Live Life Foundation in Mumbai, stating about using having girls as buddies in relation to providing information and help and support as well. That is good. In terms of, I think, a variety of activities, variety of channels, a variety of pathways to actually propagate the message of awareness of mental health literacy. And I think I would like the audience to actually ask any specific questions that you may have in relation to both in the Keralan context and also within the Indian context as well. So we will keep talking, and we will take those questions as we go along. So with all the the issues, all the kind of the health literacy and other kind of the literacy itself, the 100% literacy in Kerala. So what are the challenges that Kerala is actually facing in terms of promoting mental health literacy? Enabling people to actually take up services at the right time, both in the professional services and also any kind of self-help professional service as well, really. So what are the kind of key challenges that people in the urban and rural communities in Kerala face?
Before I forget, I think see, when we continue to increase or scale up what we are doing now, we must be very clear that there are people who are not positively impacted by our activity, or there are people whom we are unable to reach through the kind of methods or strategies which we continue to adopt. So simply by increasing the level of activity, we may not reach them. We may have to adopt a different strategy. For example, people living in remote and very distant and difficult to access areas because of geographical reasons may have to be provided a certain or more locally available activity in their place. Older people may have to be given a special attention. Disabled people will not become part of the kind of engagement which we continue with. So we will have to identify people who are left out when we roll out mental health literacy program, and then try and focus on identifying them, reaching them, and then assisting them to comprehend the kind of information which is being provided. There cannot be a presumption that a particular type of dissemination will invariably lead to understanding. Understanding is very different from access to information. And I think some people will need assistance to comprehend, and more than that, they might be hampered by beliefs and attitudes which do not allow them to take in the new concepts or meanings which we are trying to convey. So in such situations, we'll have to really see what are their explanatory models, and then explain the incorrectness or some of the inaccuracies of their belief systems, and then try to get them to take up this new information in a manner which will be suitable to them. So I think
Okay.
there you may need to fight with people who are deliberately propagating misinformation against science in general and mental health in particular. So that there might be conflict of interest in areas of their popularity or influence. That's one thing. Then I think uh, it should not be ritualistic, or it should not be on, mental health literacy activities by and large will see a sudden surge on mental health day. It's like Deepavali, you have crackers all over the country, fireworks all over the country, and then nothing. I think mental health literacy is all about making quality relevant information available to people, and then allowing people for opportunities to clarify their doubts, and then encourage them to adopt a behavior which is health promoting. I
Yes.
think we have to be uh, mindful of all these processes. Uh, and generally, most organizations tend to give away information on a particular day and a suitable time, and then presume that it will work. It may not work.
Yeah. Yeah, that's right. Yeah, thank you. I think that's an important point. We have a few questions at the moment. I'll just go through them. The first question is from Gautam. He talks about by health literacy, do we mean the general public to pick up mental health deviations or disorders from their point of view, or through a professional approach? Would you care to comment on that?
Yes, yes. I think, Gautam, I think what is important is we will have to get people to understand where health ends and ill health starts. There is a point of rarity uh, between health and ill health. When you call or designate a particular condition as a disorder, then we are saying that there is an underlying cause, there are clinical features, and there are managements which would relieve symptoms. So people otherwise will consider day-to-day life problems as disorders. That's okay to some extent, but then when people start considering disorders like schizophrenia and biological depression as day-to-day life problems, then there is a problem. It's very much like hypertension. It's very much like diabetes. All of us have blood sugar levels. All of us has hypertension or blood pressure, which is in the normal range. So there is a range of normalcy, and by and large, two standard deviations outside could be considered as one definition of disorder, though not very exact. But then that is an important criteria. I think if I can elaborate that, is that all right? 1 minute elaboration on that. For example, it is important to name the disorder. We know now that there is a condition called COVID-19. Is it a flu? Yes, it is. Is it like any other flu? No, it's not like other flus. It's a flu. It's not a febrile illness. Flu is different from other febrile illnesses. Thus, it's very different from typhoid or malaria. This is a viral infection which causes a febrile illness. Similarly, we will have to create a situation where everybody understands that there is a disorder called bipolar disorder, which affects less than 1% of the population of this earth. Less than 1% of people suffer from a disorder called schizophrenia, which is available or it's prevalent across the world in all cultures. People should also understand that all of us stand the risk of other disorders like common mental disorder. Lifetime risk is much more. Prevalence is something like 8% among adult population. And like typhoid, like malaria, like hypertension, like diabetes, these are eminently treatable. We have very effective treatments, and over time, we have better and better treatments. And there are people with these disorders on one side, and there are emerging treatments and effective existing treatments for these disorders. And that is why people should be able to identify a disorder as a disorder from normal lived experience. I think that's very important. Thank you, Gautam, for asking that
That's
question.
right. I think that's very true, because I think in the midst of the social media and everything propagating various things, and I think sometimes whole life seems to be medicalized. Even everything, a single thing that you do, a simple distress or simple anxiety that you might actually have because of whatever it seems to be considered as an illness. But I think it is important that one should differentiate what is a distress and what is an illness, and I think seek the right kind of help and support. Yeah, thank you for that. We have a second question from Ranjit, talking about what is your advice to students who seem to prey to anxiety to attend exams, especially under parental pressure?
I think anxiety, this was, I mentioned this early, because anxiety is very normal life experience. And all of us experience that. And there are situations wherein we become more anxious. That one of the situation which leads to lots of anxiety among most people is when you are about to take an exam or attend an interview or a, a performance which might have an implication for your future. So it's normal to experience. I think that is the basic understanding as part of mental health literacy we must try to provide. It's all right to become anxious. It is normal to become anxious. And you need to be worried or concerned when the anxiety impairs your functioning and leads to undesirable consequences in terms of emotional burden and persistence of anxiety in situations which actually do not produce anxiety to most people. So I think uh, raising expectations and having unreasonable expectations would definitely add to anxiety, and being realistic and practical is the way to go about it. Again, thanks Ranjit for asking that.
Yeah, I think
NGI
at
asked.
optimum, yeah, that's very true. And I think an optimum level of anxiety is actually always required to achieve for effective output, especially during the exam context. Whereas escaping that optimum level, it seems to be kind of avoidance behavior, not necessarily a kind of a mental, that's a very nature. Okay, we have a third question. It's a long question from uh, Trinjana. I think I'm correcting, saying, I'm pronouncing it correctly. Um, Looking at do we focusing on skill building and training and how to intervene to connect with professionals. You feel that there is stigma associated with mental health care, especially saying well, medications are addictive or therapy is not necessary. What's your view on that?
I think that's important. I think this is something we must be very sure and mindful before we start to engage in mental health literacy improvement activities. People do have, whatever is their level of intelligence or education, they do have explanatory models for their own illness experiences. So everyone or most people try to explain their illness experience based on their understanding, locally available information, and what do other people of their socioeconomic and cultural group tend to believe. So your own beliefs, your own attitudes, your own ecosystem, and beliefs of your peer group would actually uh, color your perception and your explanatory model. So sometimes this can be very negative and very inaccurate. Recently, I'm sure you would have heard about, people indulging in very abnormal activities like even homicide, thinking that believing in certain supernatural things. So it's quite possible that uh, most people have misconceptions and wrong notions and myths about mental illness. One common myth about mental illness, which is very prevalent in Kerala, is that there is one mental illness called Manasiga Rogam, and the cause is one, stress, Manasiga Sammardam. Third is the management, relieve the stress and emotionally support. People tend to believe that this is applicable to schizophrenia, bipolar disorder, biological depression, where you get it 100% wrong.
Yeah.
So I think, thanks for asking that question. I think let us clarify that there are conditions which are very, very different and thus requiring a totally different approach and a different interventions. Medications are needed. And another misconcept, very popular, again rightly pointed out by this question, that people again start believing that, see, for example, I had been a practicing psychiatrist in the city of Thrissur for more than almost 30 years now. They believe that if you happen to go to a psychiatrist and if the psychiatrist puts you on a medication, it means that you will get hooked to that medication and you will not recover fully and you will get addicted to this medication. Why take the trouble of going to a psychiatrist? This is what most people think. This is absolutely inaccurate and very detrimental to public health and well-being of people.
Okay. Yeah. Thank you for that. I think that's excellent. We have another question from Anisha. Talks about what steps could be taken to improve mental health training in the undergraduate level, to improve mental health literacy among doctors. Can I also mention a point here? I think in the UK, where I live and work, we also have exactly the same point. Most of the medical schools, in the medical school next door to us, they only have about half a day training in psychiatry for the entire 5-year program. So it is not just specific in India, but I think in the Western world as well, there is very little training, very little awareness amongst the medics trainees in terms of mental illness. So Dr. Shaji, can you comment on that, please?
I think a very, very important question. I think this question raises issues related to policies and plans for undergraduate medical education in particular and health science education in general. In India, BSc nursing has a better mental health syllabus and training than MBBS training. This has to change. And another, this is again my view on this. I'm sure this will be shared by many. Most of us who teach psychiatry, especially the older generation, had been trained in tertiary care centers. We were trained to handle difficult to treat mental health problems like psychosis, etc., who require admission. And thus, maybe we had made a mistake of focusing UG training on schizophrenia, bipolar disorders, and such conditions which require admissions to medical college psychiatry wards, which I think is it's not a practical step. We must instead focus on identification of delirium, ruling out delirium, building knowledge and skills to diagnose and treat depression and panic disorder, which frequent non-psychiatry outpatient settings of primary care, secondary care, and district hospital settings. If we can transform our undergraduate education to equip our young doctors to be in a position to diagnose and treat depression and panic disorder or anxiety disorder, then they will have the experience of seeing these people becoming better and relieved of symptoms. And they will start doing this when they go out and provide general medical care. And even when they become specialists like cardiologists, obstetricians and gynecologists and pediatricians, they will be able to handle common mental health problems which they encounter in their practice, and that will sustain and help to scale up mental health care in
Okay.
secondary and primary
Thank
care
you.
settings.
Yeah, thank you. We have another question from Thrissur. I'm talking about, give ideas about how we can enhance the understanding of mental health care for the wider public. I assume how we can enhance the understanding of the communities for mental health care, the need for mental health care. I assume that is part of the mental health literacy plan in terms of how mental health literacy is popular, then people might actually take up the mental health care as and when they actually require.
I think meaning this is thanks for again bringing this up. I think the future direction should include one. I think the government and the society at large should take up the responsibility of having good information available. There should be trustworthy resources to get reliable, relevant mental health information in every society. More important is also this. This has to be accompanied by strict regulation and prevention of spreading false, inaccurate, fraudulent information about healthcare in general and mental health in particular. Number two, this is again hugely important. Information, the way it is available, sometimes cannot be easily comprehended by most people who are not well versed with the terminology and the kind of dispensation which the information undergoes when that is made available. Instead, we must use metaphors, analogies, and common examples to get across these concepts uh, of identification, clinical features, and the need for care and the advantages of taking uh, care. This alone will lead to adherence to scientific approaches in mental health care. So that is very important. And I think uh, some of the good things which had happened over the last 1 or 2 or 3 years is that some celebrities, some superstars, and some important people came on board and said that yes, depression is common. I have gone through this, and I think we need to uh, get more people uh, to come out in public and say that this is an eminently treatable condition. Taking help is the right step in the right direction, and things like that. I think that's very important. I think we need to. I would request Raghu and the entire team to do a lot of introspection in this new circumstance and uh, revise and reimagine the kind of strategies which we might then want to adopt in the next year or so. Thank you.
Okay. Thank you very much for that. I think we have some, yeah, we feel quite good discussion on the questions. We are coming to the end of the interview. I don't know, we have been having an hour discussion about this specific theme about psychiatry and mental health literacy, which is actually exciting. I think we never had this kind of webinar in our context, which is actually grateful to have this. If you have anybody has got any further questions, that would be good. There is another point from Gautam stating that there is an increased mental health literacy will cause or result in tagging of individuals interpreting as mentally ill.
No, I don't think so. I think this is an important concern. The answer for that is a definite no. Because most people who has severe mental illness are very obvious in the, or their symptoms are obvious to others, and thus whether they acknowledge themselves as having an illness or not, people think that they are not normal. I think the most important mission of mental health literacy movement is to say and clarify to the general public that there are different kinds of disorders. It's not a unitary problem. It's like fever. You can have a, a small infection having fever, or so. Then when people see that depression is very common, when anxiety disorders are very common, the stigma will become less. And when people start realizing that taking help is the right step and that relieves symptoms, then there will be more takers. In fact, when we talk to general health doctors who were working in clinics or in hospitals where we had DMHP, district mental health program clinics, they said this is true even for schizophrenia. When this program was rolled out in Palakkad district, when the medical officers saw by themselves that people who were severely symptomatic earlier, when they start getting treatment, when there was proper adherence to treatment, they became so normal, and they started to get back to the community and started assuming responsibilities like people without mental illness. And that can actually reduce stigma, because people at large and health workers in particular will realize that good interventions are available, and that makes all the difference. And I think improved mental health literacy is a win-win situation.
Yeah. So I think broad mental health literacy would actually help people to actually seek support rather than actually medicalizing the whole issue, as we certainly stated. I mean, I think we will conclude soon, but there are a couple more points raised. One by Riaz, talking about how can nurses or nursing students be better empowered. I presume this is actually for improving mental health literacy and detection and treatment of mental illness.
I think very, very definite answer is already nurses and other health workers and other health professionals are playing a huge role in healthcare. This is evident even in at the time of this pandemic. I think task sharing is very, very important, and without task sharing we will never achieve the scale which we want to achieve. I think the answer is there are tasks which we can share. There are tasks which need supervision for quality and adherence, but then that is the way to go forward. I think nurses trained in mental health has a huge role to play, both in delivery of care as well as, of course, a huge role to play in improving mental health literacy, because you are the ones. See, after the clinician, nurse is, or in fact, most of the time, the caregiver and the person who suffers from a mental health problem is in close contact with the nurse than the on-call physician. So I think your attitude, the kind of understanding which you have, the scientific manner in which you handle the whole situation would have a very large impact on mental health literacy in general.
Yeah,
Thank you,
I
Riaz.
think obviously the point is actually the person who is actually suffering, and I think there is equal responsibility for the family and their friends and the employers to actually seek to enable the person to seek help. Because I think often we label the person as somebody with mental illness, which is actually quite a dangerous thing. whereas we are not actually enabling that person to help himself or herself and the family to help in that kind of context as well. So I think it is very important that it's actually seen collectively from the mental health literacy perspective. One final point, I think Trinjana has mentioned again about that once this is all actually achieved in terms of the mental health literacy of a group, maybe barefoot counseling could be a program. Yes, any form of counseling could be a program. Anything that would actually help people would be a program. Doesn't have to be barefoot. It could be foot. It could be with all the kind of stuff very well. I think it is important that anything that actually helpful, that is helpful to the community in any way. There are situations like recently the last 2 years there has been experiments in Africa. There is the kind of talking chair where the grandma sits in the chair and talks about the community talks about the whole distress, etc. So anything that is actually helpful, anything that actually promotes that mental health literacy in any community within the in any states of India, and I think that is should be the aim for the governmental and the non-governmental organizations.
I think that's very, very true. In fact, I want to quote our previous health secretary, Sri Rajiv Sadanandan, who has told many of us direct that health is such a serious matter that it cannot be left to doctors and nurses and health professionals alone. The larger community, every one of us has a stakeholding, and this is everybody's business. I think mental health is everybody's business, and everybody has a role to play.
Yeah. I think that we nearly nearing the end of this webinar. If there are any further questions, otherwise we will. Let me also finally sort of say, what is mental health literacy? People who may have actually joined at a later time, what is mental health literacy? Mental health literacy is our ability to recognize mental illness and also mental distress, some of the things that we actually talked about. And mental health literacy is actually having our awareness and knowledge about some of the causative factors that might be the trigger factors for mental illness. And thirdly, it is actually knowledge about self-help intervention, some of the things that we already talked about, some of the things that's already available, yoga, meditation, exercise, a lot of other things as well in terms of and counseling and other things for self-help interventions. And knowledge about professional help. What kind of professional help is actually available? Psychiatry, psychology, and other professionals. And attitudes. I think we're talking about stigma here. Attitudes which facilitate and promote the recognition of distress and illness, which is very much important from a society, community, and professional view perspective. And we talked about having the right kind of information, comprehensible information, easily understandable information, so which is actually knowledge about how to seek mental health information. So I think these are the 6 components of what we call mental health literacy. So which is actually very much a kind of a Western concept, but I think we want to try and see how this might actually work within the Indian context, because it is not a replication of what is the Western psychiatry model and trying to put this on the Indian context, because Indian context is very much rich and diverse, both into the social, economic, and religious and other spectrums. So we want to try and bring that into the equation of people's understanding. And how can we have an Indian model of mental health literacy and promotion of psychiatry as well? Not necessarily the kind of Western model does not actually work in all contexts. And there are, obviously psychiatric diagnosis still is a $64 million question in many respects. But I think there has to be a proper understanding. There has to be a social understanding. There has to be a cultural understanding of what people's issues are, problems are, and how we actually address those issues, both at individual, family, community, and at governmental level as well. Dr. Shaji, a final comment from you?
I think this is something which is a social responsibility. Everyone who has concerned about health should take up this if you have the time and inclination to take up this. I think there cannot be good health without good mental health. And like this pandemic had shown us, It's not about my health or your health. It's all about our health. I cannot remain healthy without rest of you remaining healthy. Same holds true for all non-communicable disorders and in particular mental health. And I think this is a journey well started. I'm sure all of us from different walks of life can put in our effort, and I'll be very happy to enlist support of institutions from the government like the Kerala University of Health Sciences uh, and self-help groups like Kudumbasri. Uh, Again, if I can add this, I think healthcare has a gender dimension. When we are ill, it's your mother or someone who is a woman who is at home who provides most of the care. True for children, true for older people, true when someone is ill. So, women workforce, working women, and women in general, if they are trained and if their mental health literacy is optimal, then we are talking about a caring society which will then hand over or uh, pass this information and knowledge across generations, because as children grow up they will be as knowledgeable as their mother or sister or whoever who is knowledgeable. And I think this is a huge opportunity, and I think we must do something which is very concrete. I'm sure the government will support and the general society will support. Thank you very much for this opportunity.
I think that's
Thanks,
yeah,
everyone.
that's a very important point in terms of gender equality and actually empowering women from diverse communities and also people from a lot of socioeconomic spectrums as well in terms of understanding mental illness. So it is very crucial. Anyway, it is an enjoyable discussion. We've gone over an hour and 15 minutes. Thank you very much. All of you have joined us. I hope to see you again on in mid-February, where when we have the next webinar on promoting mental health literacy. Follow us on our Facebook page and also on Twitter. And any other comments that you may actually have, we are actually available on the World Wide Web and also on YouTube. So do actually raise your concerns, and thank you for watching us, and thank you for your questions, and thank you for your help and support. And we continue to build on the community support from people like you with this engagement. Talking about mental health is actually extremely important, and I think that makes us more knowledgeable. More, I think it eradicates some of the illusions around mental illness and mental distress, and how we actually get the right information from that. So, thank you ever so much. And my special thanks to Dr. Shaji for coming on and discussing this in a very simple manner, in a very casual style as usual, and very much for your wisdom and your insight into some of those communities, the illness, and the kind of models, etc. And we hope to, work with you again and bring you into the context again in terms of further discussions. Many, many thanks to you. And also thank you, Parvati, for hosting this, the first webinar on promoting mental health literacy in Kerala as part of the ongoing mental health webinar series. So our plan is to actually have a webinar, two webinars in a month, the middle and the end of every month. So the next one would be for the middle of February. So hope to see you all soon. Thank you and have a good afternoon from the UK.
Thank you, thank you. Thank you, Raghu. Thank you, Parvati. Thanks, everyone.